Hello, my name is Rob Leffler. I'm the Vice President of Clinical Services for PCA Pharmacy. I'm going to be talking about the CMS 5-star rating system and specifically the quality measures domain. There are three different components that determine a facility's 5-star rating. The first is health inspections. That's based on annual surveys and complaint investigations. The second is RN staffing and total nurse staffing, which is case mix adjusted on data from the MDS assessments. And the third are the quality measures. This is based on performance on 16 of 24 quality measures found on Nursing Home Compare. It gathers data from MDS assessments and also from hospital and ER claims. So going on more specifically about the quality measure domain, it's a set of quality measures that have been developed from the minimum data set, or the MDS, and Medicare claims data to describe the quality of care provided in any nursing facility. The facility rating for the quality measures domain is based on its performance on a subset of 13 out of 24 MDS-based quality measures and 3 MDS and Medicare claims-based measures that are currently posted on the Nursing Home Compare website. This information gets updated quarterly. The ratings are based on 4 quarters of data. The reason they use 4 quarters of data is that way they can increase the number of assessments available for the rating and thereby improve the stability and reduce the probability of missing data. The data is considered quarterly and then it gets combined into a score. For the claims piece, the MDS and Medicare claims piece, they do use a full year of data rather than breaking it out by quarter. The MDS-based quality measures are updated on the Nursing Home Compare website quarterly, and the Nursing Home Quality Measure rating is updated at that very same time. It happens around the middle of the month in January, April, July, and October. Claims data is updated every 6 months in April and October. For long-stay quality measures, patients that are at the facility for greater than 100 days, this data is gathered solely from the MDS. These are the 9 items that they look at. First of all, it's a percentage of residents who need help with activities of daily living. Their needs have increased. They have to increase in at least 2 late loss ADLs by at least 1 level, or in 1 late loss ADL by more than a level. Those late loss ADLs that are reviewed are med mobility, transferring, eating, and toileting. So it's very important that ADL scores are entered correctly into the MDS. They added a quality measure in July of 2016, which was for the percentage of residents whose ability to move independently worsened. They consider the percentage of high-risk residents with pressure ulcers. They're looking at pressure ulcers or sores that are staged 2 to 4 in high-risk residents. That would indicate that a resident has impaired bed mobility or transferring. They might be comatose or have malnutrition. The 4th category is the percentage of residents who have or had a catheter inserted and left in their bladder. In the last 7 days is actually the look back that they used for that. They do this because of the risk associated with complications like infections, injuries, skin problems, bladder stones, etc. This does not trigger if they have a diagnosis on the MDS of neurogenic bladder or obstructive uropathy. So if you have a patient with a catheter and they have one of those diagnoses, it does not count towards this percentage. Next, the percentage of residents who are physically restrained. When patients are physically restrained, they can become weak and lose ability to toilet on their own and develop pressure ulcers and other complications. They look at patients with a UTI that is actually a UTI that's coded within the last 30 days. This can lead to more serious problems and complications. It's important to not code a UTI unless there are very specific indicators for it. They need to be treated with an antibiotic. They have to have a lab value over 100,000. They have to have a diagnosis, and they need to have the signs and symptoms of a UTI. So if you have a diagnosed UTI, but there aren't signs or symptoms, or it's not treated, or it's colonization, it's important that it not be coded as a UTI. Pain, percentage of residents who self-report moderate to severe pain, that would be in the last 5 days, or also if they indicate that they have very severe or horrible pain in the last 5 days. Percentage of residents experiencing 1 or more falls with major injury, they actually look back at a full year for that. Percentage of residents who received an antipsychotic. So that's receiving an antipsychotic in the target period. CMS has been focusing on antipsychotics for some time now. If they do have a diagnosis of Tourette's, schizophrenia, or Huntington's, it will not trigger this percentage. There are these 3 quality measures that are risk adjusted. The percentage of residents whose ability to move independently worsened, catheter, or percentage of residents who self-report moderate to severe pain. What I mean by risk adjusted is, for example, like catheter, they're going to look at patients that had bowel incontinence or pressure sores on their prior assessment, so that would indicate that they would be at greater risk of having to have a catheter. So it is risk adjusted. For short stay quality measures, data from only the MDS, there are 4 short stay quality measures added in July 2016. The percentage of residents whose physical function improves from admission to discharge. Percentage of residents with pressure ulcers or sores that are new or worsened. Percentage of residents who self-report moderate to severe pain. Again, with the pressure ulcers, it would be a pressure ulcer that's a stage 2 to 4, moderate to severe pain, or horrible or excruciating pain in the last 5 days, much like we saw with the long stay quality measures. And the percentage of residents who newly received an antipsychotic. Important thing here is that if they come in on an antipsychotic, that it gets coded on their initial MDS assessment, because they will compare. So that would be, you would see an MDS that didn't code an antipsychotic, and then the next one did, so they're newly receiving an antipsychotic. With the mobility, in the first one, we're looking at transferring, locomotion, and walking. Several of these are risk adjusted as well. That would be patients whose physical function improves and pressure ulcers. Short stay quality measures that is gathered from both claims data and MDS data. These are measures for short stay residents. The percentage of residents who are rehospitalized after a nursing home admission. The percentage of residents who have had an outpatient emergency department visit. And the percentage of residents who were successfully discharged to the community. And all 3 of these are risk adjusted based both on Med-A claims from hospitals and ERs and the patient's initial MDS. When we talk about scoring for quality measures, each of the quality measures is scored anywhere from 20 to 100 points. The new quality measures in July use 50 points. And they're assigned based on a facility's performance relative to the national distribution of the quality measure. When we talk about health inspection scores, which was the first domain that's used for the 5-star system, it's based on a comparison with the state. With the quality measures, it's based on the national distribution. Points are assigned after adjustments are made for missing data. Ratings for the quality measures are based on 4 quarters. The reason they do that is to increase the number of assessments available for the rating and thereby improve the stability and reducing the chance of there being missing data. The data is considered quarterly and then it is combined. For the claims base, they do use a full year of data all at once rather than breaking it out by quarter and then combining it. For quality measure scorings, for the long stay quality measures, the ADL worsening, pressure ulcers, catheters, urinary tract infections, pain, and injurious falls. And in the short stay category, the pain, the facilities are grouped into quintiles based on the national distribution of those quality measures. The quintiles are then assigned 20 points for the poorest performing quintile, 100 points for the best performing quintile, and then 40, 60, or 80 points, depending on which quintile they fall into. For the long stay physical restraint, facilities achieving the best possible score on the quality measure, which would be 0 residents with a physical restraint, get 100 points. That's about 60% of facilities, or 3 quintiles. So they couldn't divide out the scores like they did with the previous screen. The remaining facilities are then divided into 2 evenly sized groups. Each of those have about 60%. The poor performing group is assigned 20 points, and the better performing group is assigned 60. So there's 20 points in the bottom group, 60 points in the next group up, each about 20%, and then the top 60% all get 100 points. The short stay pressure ulcer is treated very similarly to the physical restraint quality measure. Facilities achieving the best possible score here are assigned 100 points, and this is about 1/3 of nursing homes. The remaining facilities are divided into 3 groups, each being about 23%, and assigned 20, 50, or 75 points. For the long stay antipsychotic medication, the long stay mobility decline, short stay functional improvement, and all 3 of the claims-based measures, the facilities are grouped into 5 groups based on the national distribution of each of those measures. The top performing group, the top 10%, receive 100 points. The poorest group, or the bottom 20%, receive 20 points. The middle 70 is divided into 3 equally sized groups and receive 40, 60, or 80 points. These were added to the 5-star system in February of 2015. The short stay antipsychotic medication quality measure is treated very similarly. It was also added in February of 2015. In this situation, about 20% of facilities achieved the best possible score, or 0% of residents on a short stay antipsychotic. Those facilities receive 100 points. The poorest performing group received 20 points, and that's about 20% of facilities. The rest are divided into 3 groups and receive 40, 60, or 80 points. For the MDS quality measures, they looked at 2016 for the claims-based quality measures and claims data. They used the 3rd quarter of 2014 and the 2nd quarter of 2015. Those numbers are all combined, and they get a total score, and then that score is compared to this cut point table for the MDS quality measure summary score. You can see that the higher score the facility receives, the more stars they receive. So the lowest point that anybody got in July of 2016 was 275, going all the way up to 1,350. These are divided out into about 25% of the facilities receiving 5 stars, about 15% receiving 1 star, and 20% receiving each of 2, 3, and 4 stars. If a facility is missing data, this is taken into account, but it does get rather complicated. MDS-based QMs are reported if they have at least 20 assessments across 4 quarters of data in both a long and short stay. Claims-based are reported if they have at least 20 nursing home stays over the year. If there is data that is missing or there aren't enough assessments, then available data is used and the remaining assessments are added to get a minimum of 20. So for example, if a facility only has 12 of the antipsychotic quality measure, then they would add 8 more from the state average to make a total of 20 in addition to the facility's 12. For long stay to be counted, they do need to have at least 20 in at least 5 of the 9 long stay quality measures. For short stay and claim-based, there are 7. They have to have at least 4 that they have 20 assessments in of the 7 to be counted. If they don't have enough data, then they only use the areas where there are enough assessments. And they do also have a method for rescaling both long and short stay facilities. Here's an example of a QI report. You can see on the second to the bottom line, their antipsychotic use was 0, and their denominator was 42, so their reported percentage is 0. So this would be one of the facilities that would get 100 points on the antipsychotic quality measure. You can see from the technical users guide, which there is a link to at the end of this presentation, that would be this top section, the 0%. They do get 100. For 20 points, it's anywhere from 3 to 100%. To calculate an overall rating for a facility, you start with the health inspection rating and determine the number of stars they receive. Then a star is added if they receive 4 or 5 stars on the staffing rating, and the staffing rating has to also be greater than the health inspection rating. 1 star is subtracted if the staffing rating is only 1 star. Then an additional star can be added if their quality measure rating is 5 stars, or a star can be subtracted if the quality measure rating is only 1 star. The overall rating can never be more than 5 stars or less than 1 star. The reason that the upgradability of the star rating is limited is because they didn't want the 2 self-reported data domains to weigh too heavily on the final score. They felt like the on-site visits from the surveyor should be weighed more heavily, and that should be more heavily weighted towards the more recent findings. If the health inspection rating is only a single star, the overall rating cannot be upgraded by more than 1 star based on both the staffing and quality measures. If a facility has no health inspection rating because it is too new to have 2 standard surveys, then no rating for any domain is displayed. If they only have 2 standard or annual surveys, the most recent receives 60%, the prior survey receives a 40% weight. And again, if they only have a single standard or annual survey, there is no composite rating and no staffing and quality measure domains. Here are the websites from CMS and Medicare.gov. The 5-star ratings information can be found at Medicare.gov, Nursing Home Compare. The state cut point tables, and that specifically refers to the health inspection scores, can be found at CMS.gov. And the 5-star quality rating system technical users guide link is there, and that is where the majority of this information has come from. It's a very thorough document and an excellent resource to review. If you do have any questions about the 5-star rating system or any of the domains that go into a facility's 5-star rating, please don't hesitate to reach out to me, Rob Leffler at PCA Pharmacy, or Natalie Dom at PCA Pharmacy. Thank you very much.